Hello, everybody, and thank you so much for joining us tonight for this expert collaborative review of the treatment of sacroiliac joint pain brought to you by ASPN and SIMEG. I'm going to go ahead and hand it over to Dr. Syed, who's going to be a moderator with Dr. Donner tonight.
Thank you so much, and thanks everyone for joining us tonight. I think this is really going to be a really outstanding webinar for all of you, that have been able to get on and spend your evening with us. So, I think the sacroiliac joint has been, I think a little bit of a neglected cause and etiology of low back pain for, ever since we've been treating patients with lower back pain. And I think, part of that has to do that, a lot of us have been trying to treat this disease in a silo in our own specialty. And I think really probably the key to kind of really getting to the bottom of how to most effectively treat this disease entity and figuring out what the best treatment options are is for all of us to collaborate. Those of us from different backgrounds and specialties really do hold the key to really unlocking, I think this kind of, I would almost call it a medical mystery for a lot of the times. As you know, from a lot of the literature and data, 30% of patients that come into our clinics for lower back pain, a lot of it's coming from the SI joint. And I've seen it throughout my kind of younger career be misdiagnosed and mismanaged for a lot of times. I think though, with collaboration, and I've been, honored over the last, several months to learn about the SIMEG organization. Dr. Donner's I believe now the immediate past president of SIMEG, and he's done a lot of great work in this field, a pioneer in sacroiliac joint disorders, and he's done, wonderful work. And we hope to learn from, the work that his organization has done. And ASPN, we've also been really interested in, improving the education and the clinical efficacy of a lot of the pain therapies out there, including the SI joint. So with that, I'll jump into the agenda a bit, and then I'll let Dr. Donner kind of speak about the SIMEG organization a bit. Can we go to the next slide, please? Actually, we're going to go with Dr. Deer, who can't make it with us tonight, but he did want to give a brief video message to all. So let's have Dr. Deer say a few words.
Hello, friends. Welcome to this webinar where we take Dr. Dawood Syed from ASPN, Dr. Jeff Donner from SIMEG, and we bring together like-minded individuals who want to help patients. When we talk about collaboration, not turf wars. We talk about patient-focused care, not really what's best for the doctor, but what's best for the patient and the physician and the team. In this discussion tonight, you hear about new innovations, patient selection, and which approach, whether it be posterior, lateral, or some hybrid, is best for your patient going forward. Also, we'll talk about the research, the outcomes, complications management. So I'm hopeful tonight changes your practice, changes your thought process, and really brings us together and improves collaboration between across specialties treating this complicated patient disorder. So with that, enjoy the discussion.
Well, thanks for that, Dr. Deer. There was a little bit of technical difficulties there, but I think we all got kind of the gist of his message there, collaboration and looking at this from a very kind of collaborative approach. And here's the agenda today. Dr. Donner here in a few moments is going to give us a brief overview of the SIMEG organization and their structure and their history. Then we're going to go into the interventional treatments for SI joint pain. We'll talk about multiple panels here, various approaches to the safety issues and outcomes. Then we'll talk about various approaches for SI joint fusion devices. And then we're going to have safety and risk of sacroiliac fusion approaches and talk about data. And then we'll have a very brief update on billing and coding for sacroiliac fusion, as that's undergone some kind of notable changes here in 2023. With that, Dr. Donner, please take it away.
Well, thank you very much. And I first want to thank ASPN for the effort in putting this together. I think it's way overdue. Our last board meeting for the SIMEG in November, we made it a priority to reach out to other colleagues in this field because we know we can learn from everyone. And specifically, those who took this SI joint problem on way before surgeons. I think it's due to you in the non-surgical world of treating patients that, we recognize that, and we can't just overlook it, especially as your group has become more influential in the actual treatment of the joint beyond injections and radiofrequency ablation. With that, I'd like to introduce SIMEG briefly. If you go to the next slide, please. And this was actually formed in Germany about 10 years ago. And it was surgeons who got together and were trying to find answers for this pain in the pelvic girdle area, primarily in the buttock. And with that, I recall getting a call about 8 years ago from Volker Fuchs in Germany saying, hey, we see that you're interested in this space. Would you join us for our annual meeting? And it kind of went from there. So it was really a surgeon-focused group. Not that it was exclusive to it, but it was that group that got together. Next slide. And again, it was based on the fact that surgeons were looking for answers. And the idea was not only to educate ourselves, but others, and not only surgically treating the SI joint, but making the right diagnosis. And I think one of the key aspects of our board decision on how we would approach this is be unbiased. You know, whether it comes from our colleagues who are physical therapists or chiropractors, or obviously anesthesia is a very big part of pain management, but so are physiatrists and other people in the medical specialty. So when we talk about unbiased, it's not only just our surgical perspective, but also try to be free of industry influence, although we recognize the value of industry and making sure we have the right tools to help our patients. Next slide. So this is kind of the background, just briefly, you know, who was involved over the years. And you can see it's a very diverse group. We have now Asia with our new president, Daisuke at the top. Dr. Freeman had been around before me, who did a great job trying to integrate us with the U.S. Surgical societies, specifically ISAS. You know, Woody Cross from the Mayo Clinic, who's part of this panel discussion, will be available. And he comes from a different angle. He's an orthopedic surgeon, but he's a trauma specialist. Dr. Freeman is a neurosurgical spine SI specialist. So we get a lot of diversity. The other side, we can see Dr. Pauly at the University of Minnesota. We have our Swiss colleagues, Dr. Martin Blay, and then Vic Patel at the University of Colorado. Tom Kipsgaard was a leading, as you can see from this slide, he's been involved for a long time, and he does a lot of research, got his PhD actually in investigating the SI joint motion, and he's at the University of Oslo, Norway. Next slide. What we try to do is obviously not only get together and talk to each other, but also create educational programs. We have our own within the SIMEG organization, as you can see, and they're very well done. We did some debates more recently just because there's issues that deserve not just a lecture, but going back and forth and presenting your case, including SI fusion versus fixation, as you can see on the right-hand side. That was about a year ago or so. And Dr. Cross was involved in that one at a high level. You can see there's a safety symposium. That was the last one that Dr. Freeman was in charge of in terms of looking at the safety of certain devices. And he debated with Dr. Pauly on this issue. More recently, Dr. Cross was invited to speak at STED, which is the Spine Technology and Education Discovery. And that's through Jens Chapman's educational program out in Seattle. He talked about revision strategies, and he'll be available today to help us understand the importance of trying to get it to work the first time and what kind of toll this can take on patients if it doesn't happen the first time. Next slide. Some of these debates, as you can see, you know, there's a difference of opinion, but even though they can be a tough battle, you know, we try to, you know, get along. And this is, you know, one of those events that just occurred. You can see it was a tough fight, but they're all having a good time. Next slide. Beyond fighting, we also like to recognize people who have been in the space for a long time, including Bruce Dahl, who's published very, not only just scientific and biomechanical and outcome studies, but he's also involved in encouraging our academies and our teaching education of the SI joint while they're in training and not having to scramble when they get out and have industry teach them how to do this. So we would like to recognize those people in our societies. Next slide. So you can see when you go on the website, if you go through it, I think it's valuable. One of the things we'd like to point out, you see a section for surgeons and non-surgeons and special interest groups. And the whole concept here is to bring people together like we are today. Next slide. My background, just to be brief, without my whole CV, I am board certified in both orthopedics and spine surgery. I'm a member of many societies, but I've been in the same area in Northern Colorado for over 30 years. And when I got here, I realized I really wasn't able to help a lot of people who were waiting to see me because I was one of the first spine specialists. And I couldn't even really tell them where their pain was coming from most of the time. And so with that, I had to be more involved in your types of societies. And at that time, it was ISIS, if you remember, which was converted to SIS, or the Spinal Intervention Society. And I learned more from your groups in this regard than I did from my surgical colleagues. So based on that 30-year history, I was able to actually obtain a better idea of the pain generators, doing my own discography, facet injections, nerve blocks. And at one point it was like, well, your pain, I couldn't reproduce. Now, where is it on this fluoroscope? And I would put a metal marker over it. It was over the SI joint. So I started to inject that, and there was a large group of patients that, got better, and obviously not all of them would stay better. So then it became more of a challenge to find out how the best way to, surgically solve this problem, just like we do with the lumbar spine. We all have different approaches, as you know, from anterior all the way around to the posterior aspect. So we did this as well. And I believe that whatever approach you do use, we just need to stick to the AO principles of fusion. And that includes obviously removal of the cartilage, the painful surface of where we think a lot of this pain is coming from, and then decorticating down the bleeding bone, bone grafting, rigid fixation. And I believe this is the gold standard that we need to try to attain if we can. Next slide. From there, we have moved on to our new president, who's in Japan. And you can see back in 2009, they also started getting more involved in creating a center where they bring people together with different perspectives. They have a lot of experience doing the anterior approach. And as you can see from this slide, they became more of a posterior approach type of general philosophy. And they find different ways that they can actually inject the joint, both for diagnostic and therapeutic purposes. And this is primarily led by our president now, Daisuke Kurosawa. And next slide. This is the kind of research group they had. It's diversified, and it includes physical therapists all the way through the surgeons. And he told me on their last webinar, I think it was November of last year, they had over 200 people participate. So that's a very good sign that they are integrated and moving in the right direction. I believe that Daisuke may be available for a few comments. I didn't see him sign in, but there he is. We could introduce our president here.
My camera couldn't show me. I'm sorry. Thank you for the opportunity to collaborate with ASPN. Our group, SIMEG, is very happy to have new SIJ experts from different fields. Today, I'm looking forward to learning SIJ treatment methods from ASPN. Thank you so much.
Well, thank you very much. We can move on to the next section.
Well, that was a wonderful introduction to the SIMEG organization, and it was really a pleasure to have Dr. Kurosawa say a few words. I know he's all the way in Japan, so that's a challenge with the time difference. So looking forward to actually seeing you in person sometime, Dr. Kurosawa. Really impressed with the work your team's done in Japan. So our next, if Dr. Donner, if you could jump back on here too and actually help me grill these guys and gals on the next section here. So we're going to talk about interventional treatments for SI joint pain, injections, ablations, and regenerative medicine techniques. So Dr. Reese, you're a physiatrist, and I think, what's going to be nice today is we're going to have folks from all different backgrounds today. From a physiatry perspective, when you're diagnosing a patient, and just kind of take this to the basics, what are kind of the basic physical exam maneuvers that you think are the best, in your opinion, to really kind of knock down this diagnosis? Because diagnosis is the key here.
Absolutely. As with a lot of things in pain management, the right patient, the right diagnosis, often will get you the best outcomes for your treatment. As far as physical exam maneuvers, certainly there's high sensitivity for a lot of these maneuvers, but the specificity is kind of inconsistent across the board. So we need to stack together a lot of the physical exam maneuvers that are, having concordance with the with SI joint pathology. So Faber is very common, but it's also misconstrued because a lot of times patient will do a Faber and the patient will just be saying that they have pain. So you want to be making sure that that pain is referred to the posterior, buttock region as opposed to the groin, as in a hip examination. You also want to be looking at things like a Fortin finger, as basic as that is. It's actually pretty sensitive for SI joint dysfunction, within 2 centimeters above the PSIS. Gaineslands is another nice maneuver that I think has been pretty coordinate with SI joint pain, as long as you stack these together with, the Fortin finger and then also a Faber. That helps to kind of guide and reassure you of your diagnosis. There's sacroiliac joint compression tests that are helpful, but obviously we also look to our interventions, and so the MRIs and imaging, honestly are most likely not going to be that helpful, and oftentimes we don't see any pathology on those imaging. So we go to our guided injections, which I think we all know. Sometimes we're not intra-articular and sometimes we are, and so trying to be as consistent as possible at getting inside the sacroiliac joint to help that guide your diagnosis is also going to be key. And I think that some of the newer literature out there, with the SI fusions, I think Pat Buchanan and David Lee put out some with the far contralateral oblique approach. I think has been very nice. I've actually incorporated that into my practice pretty routinely, and seen a lot of good results with sacroiliac joint diagnosis.
Yeah, thanks so much, Dr. Rees. Those are really excellent points. Dr. Donner, would you like to give one of our panelists the next question?
Yes, so if everybody's speaking about different things, I just want to make sure, or just in general, because I see injections, ablations, regenerative medicine. I can just give you.
You can hit these with anything.
Yeah. So let me just say, I use all the exam. I'm fortunate I have a fluoroscopy, a unit in my office and procedure room. So a lot of times I'll just go down and do my workup. I believe that, the 80-20 rule, if 80% of the pain's coming from the lumbar spine, you got to do a lot of work on the lumbar spine before you start looking at the SI joint, just based on the odds. So with that, I think it's almost a diagnosis of exclusion. You exclude the lumbar pain generators, and then, because I've been fooled so many times, even with injections, especially if you don't use low volume. So with that, I was wondering what your, whoever would answer the question about what kind of volume do you use when you're doing the injections for diagnostic versus therapeutic. Personally, therapeutic, I'll use a big 6 cc's. I don't care. I just want to get their pain to go away. But it comes down to diagnosis, I'm down to 2.
Aaron, you can take it. I don't know if Dr. Lee could hear us.
Sure, I'll be glad to take it. Yeah, Dr. Donner, I agree with you. For diagnostic injection, you want to keep your volume down. I think 2 cc's, 1.5 to 2 cc's is plenty. I agree with you completely. Therapeutic, if there is a role for therapeutic injection of the SI joint, I'd love to hear your opinion on that. Certainly the volume can be greater, but we know that, it's very common to have a capsular defect or a rent in the capsule. And it's very common, even if you're in the joint, to see some spillage out of the joint, which could potentially besmirch the precision of your diagnostic SI joint injection. The other thing I'd like to bring up is that, there may be a role for looking at the SI joint also by way of thinking that some of these patients may have most of their pathology in the posterior SI joint complex and not intra-articular. And those are the patients that might do well with radiofrequency ablation and diagnosis by lateral branch block rather than intra-articular block.
Good point. Yeah, when I do inject, again, I don't really care where it's coming from. They have pain in their buttock, and if it leaks out, which we know vast majority do. I have very few patients where I've taken the syringe off and I see fluid come back, like you see in a facet joint, for example. So we know it leaks, and therapeutically, it probably leaks in posteriorly as well. So that could be what. But when it comes down, am I going to do an intra-articular fusion on someone? I do that low volume intra-articular.
Yeah, really nice. Jennifer, you might still be having audio issues. It seems like. Are you with us?
Are you able to hear me?
Oh yeah, I can hear you now. Great. So Jennifer,
yeah, perfect. Thank you.
You've done a lot of work with RF ablation of the sacroiliac joint. Can you kind of take us through kind of what your technique is and how you kind of select these patients for an RFA procedure of the sacroiliac joint?
Yeah, no problem. So I would congratulate Dr. Reese gave an excellent description of the physical exam maneuvers for identifying SI joint as the etiology of pain. You know, probably the one diagnostic test that stands out as the most specific would be our dual diagnostic blocks of the innervation posteriorly to the SI joint. So the innervation of the SI joint is been studied in cadaveric models for 20 years, and there is definitely variability, but there's pretty good consensus that L5 dorsal ramus through S3 are the nerves to target primarily. It's about 8% of people that have the L5 dorsal ramus contributing, and 88% S3. So those sacral nerve roots, those lateral branches, I should say, are really critical to adequately ablate. So if a radiofrequency ablation is not my first treatment. My first treatments are conservative, physical therapy, and intra-articular injections. But if a patient is not getting sustained relief of pain, I use those diagnostic blocks in order to confirm that diagnosis. And if I'm reassured that I am truly trying to treat a pain that is generated in the sacroiliac joint, then ablation of those nerves is our next step. So the nerves that I target are the L5 dorsal ramus, the S1, S2, and S3 lateral branches. Dr. Stout and Dr. Dreyfus have done considerable work, published and really professed in SIS as the standard for doing ablations to these blocks or to these nerves. The block involves our usual strategy for, I should say, ablation involves our usual strategy for dorsal ramus thermal neurolysis, and then for our S1, S2, and S3 lateral branches. There's a really excellent paper that was published, I think it was 4 years ago, in Pain Medicine that has a beautiful description of the variability in the lateral branches relative to the dorsal foramen on the sacrum of S1 through 3. And the idea is to place the needle tip lateral to the neural foramen by about 10 millimeters. And then to ablate the targets for the probable locations that are described in that paper. If that paper was designed with the idea that those would be monopolar lesions, and therefore it would require multiple. In fact, it's a really time-consuming procedure, not always an enjoyable procedure for that reason. So there's alternate options in order to speed that up and to more efficiently ablate. The ways to do that are looking at use of bipolar radiofrequency. Many older doctors may be familiar with Simplicity that was available along a single radiofrequency probe that spanned the distance between the L5 dorsal ramus and the lateral branch of S3. And then there's other strategies that are being kind of explored in our space for efficient ways to reach all those nerves.
Really great answer and review on that. So I think we're kind of coming up on time, but just one more question for everyone. Dr. Kolodny, is there a role for regenerative techniques in SI joint disease?
I think that there's probably a role for the use of PRP for SI joint pathology in patients that are very interested in something other than ablative procedure or a fusion, and are not interested in repeated steroid injection and have already failed physical therapy. But there's not a lot of data. There's a single RCT that was published back in 2017 by Dr. Singla with about 40 patients. And the results were reasonably good for the efficacy of PRP. There's been 2 other case series published. One was by Anu Navani, who's in California, also with reasonable results. But you know, this is not like level 1 or level 2 studies, and there's no good published study on the use of bone marrow concentrate for SI joint mediated pain. So, you know, in my practice, I'll use PRP, SI joint intra-articular occasionally, or in the ligamentous structures, but it's not a first line option. And there's a fairly good review, a systematic review that was published by Zach McCormick and Taylor Burnham, who is Rob Burnham's son. He's a young physiatrist in Canada. And it talks about the lack of really good data for regenerative treatment of the SI joint. So not first line, but it's certainly an option for certain patients.
Thanks so much, and thanks to all our panelists on this panel. It was a really great start to the webinar. So let's jump into the next section. I think we have Dr. Freeman up next. Dr. Donner, you care to give him a brief introduction, please?
Yeah, sure. Dr. Freeman's at the University of South Florida, where he's been almost his entire career. He is, I would call, the neurosurgical expert on SI joint. How he ever fell into this, I don't know. He always says you have to be somewhat crazy to be a neurosurgeon to begin with, so this shows he's at the higher end of that crazy scale. But he does really care about his patients, and he's not prejudiced. He wants to know what's wrong, and he wants to find the best way to fix it. So I'd like to introduce my colleague, my friend, Tom Freeman.
Thank you very much. Okay. So basically, the purpose of this talk is to show the pitfalls of SI joint surgery. We're talking minimally invasive surgery versus mini open surgery. They're similar in a lot of ways. The conclusion is I don't think we're there yet. I don't think we have the perfect embodiment yet. And I think eventually this will be something that many different types of practitioners, not just orthopedic surgeons and neurosurgeons, can do. But I don't think we are there yet, and I'd like to show why. So those are my conflicts of interests. SI bone, as most of you know, is pretty much cornering the market at this point with about 2/3 of all the devices being put in. They've certainly done the heavy lift. I use them myself, and I've had some very good results until I didn't. And I had one patient that was a near miss where I almost killed them. The operation was going quite routinely until I got massive bleeding from the superior gluteal artery. And in less than 1 minute, the hemoglobin went from 12.1 to 5.9, just in about the 45 seconds while I was impacting the third device, which is a loss of half the blood volume, class 4 hemorrhage. The patient almost died. And the manufacturer narrative on this is that bleeding is a known inherent risk of surgery. But I'm going to call that's just not a fair description of what I was encountering. That was a life-threatening bleed that was uncontrolled for 45 seconds and almost killed the patient. So let's talk about the different trajectories and what are the issues. There's over a dozen different trajectories, but there's 3 major ones that, from my point of view, the first being the lateral approach, most common, then there's a posterior distraction interference, and then finally posterior inferior. What they have in common is minimal blood loss. They're minimally invasive or minimally disruptive, generally well tolerated. They all work about 80% of the time in my hands and in most people's hands. And the goal of surgery is make them safe, effective, fast, no fiddle factor, easily reproducible, 2D imaging for outpatient setting, if that's where it's going, teachable, and can be done by a lot of providers. Not all devices are equivalent. The bone dowels are getting a very bad rap, not only for misplacement, as you see in the bottom right, but for lack of fusions. These cortical bone grafts don't have a blood supply and they don't fuse. And almost every surgeon I know now has an entire hard drive of pictures like this. And I don't think they're going to last very long. And there are certainly people being injured without possibility of benefit. So this is not, I don't think, going to take over or do well long term. There's a lot of device specific issues. We can't get into this. And then there's several different mechanisms: compression across the joint, stabilization of a joint, and then distraction interference. They all have merits. That's an entire talk by itself. And these are the different approaches and things we're trying to avoid: staying out of the belly, staying out of the neural foramen, staying out of the spinal canal. There's a lot of bad things here. The claimed benefit of SI bone is all these things FDA approved, and they claim minimal blood loss, which is true until it's not. This is a single slide summary of about 100 papers, but the bottom line is they all seem to be very reproducible in terms of speed of recovery and magnitude of recovery following use of the SI bone device. But having said that, these are efficacy papers, not safety papers. There's over 30 companies coming out with lateral approaches. SI bone is coming off patent very soon, so there's about to be an explosion of these lateral devices and the complications. So let's talk about the complications. On the MAUD website, when Bruce Dahl wrote this up, and it was published in April of 2022, there were already 1,000 plus severe adverse events on the MAUD website. This is self-reporting, and nearly all of them were with the SI bone device, including 3 deaths, all associated with hemorrhage. Half of the reports had malpositioning, 58% had nerve root injury, 92% required revision surgery, usually or often emergently. And the company, when they reviewed this, said that 60% of these were due to surgeon error. My question is, if there's that many errors, is this a process error or a surgeon error? When I looked at this myself, I also found 50 plus significant hemorrhages, 40 pelvic fractures, anterior sacral cortex and intra-abdominal violations, and device non-unions. And now there's well over 1,500 SAEs. So my premise is that this is not surgeon error, this is a system error. And I think this device and lateral approaches in general need to be looked at from a safety perspective more than an efficacy perspective, because it's got the most safety problems of any possible method. And it's really mandatory to continue alternative device innovation because of these safety problems. So what I'm going to do very quickly is give you the classes of problems. And I'm not even talking about S2 AI bolts and S2 screws, which is for invasive spinal constructs. So the relative risks that are elevated with lateral approaches, and this is now going to be for all 30 different devices coming on market and all the Me Too devices coming on after the patent runs for SI bone. The adverse events are unpredictable. They're unavoidable vascular injuries, including death. There's unpredictable and unavoidable neural injuries. There's intra-abdominal injuries, failure due to stabilization in the soft sacral ala, and lack of a bony fusion of the sacrum to the ilium. There's a lot of other risks, including myofascial disruption, pelvic fractures, damage to the SI joint when the device fails, including with clinical worsening, variable outcomes. The company defined a 20% benefit as a success. That's a failure in my books. It's got to be greater than 50% improvement to be worth the risks of surgery. And revision surgeries are uniquely challenging and have limited availability in the United States. If a device fails 20% of the time and there's not enough people doing revisions, that's a failure. that can't be fixed. These elevated risks are specific to the lateral approach and the SI bone device in particular. So let's talk about the anatomic structures at risk. There's the superior gluteal neurovascular complex, and I'm sure most of you have seen this picture. This is where the SI bone devices are placed, and it's in quite close proximity to the superior gluteal nerve and artery. And the issue is with dysmorphism, the pelvis rotates and the artery is closer to that trajectory. And the risk is multiplied by 3 when 3 implants are used. In cadaver studies, which are not patients with mobile arteries and nerves that can move out of the way, in the study by Collins, 18% of screws at the S1 level, which is the safest level, caused damage to the superior gluteal branch of the superior gluteal nerve or artery. And that's a big number. That's very different than what's reported clinically. But Eastman projected a 10% injury rate for S2 trauma screws, and suggested alternate trajectories may lower the injury rate. And this is just a picture showing impingement in the neurovascular complex in the Collins article. And then once again, it's much higher in the dysmorphic pelvis. So this leads to the unpredictable and unavoidable injuries, including the 3 deaths, and then the numerous hemorrhages and near-death experiences, such as the one I reported. So abnormal anatomy in the SI joint is actually normal, because so many patients that have SI joint pain also have dysmorphic pelvises, which will increase neurovascular risk even more. In the clinical reports, it's reported about 3 to 4% of cases, but I don't believe this, because very often when there's bleeding, it's just packed with gel foam. It's not even mentioned in the operative report, because very often it can be tamponaded. And so when you talk to people doing this, very often they say it's not even a problem, it's not a complication. So I think that the 3 to 4% of cases is more the significant hemorrhages rather than all hemorrhages. And it may have to be dealt with emergently, and you need to have all hands on deck and experience in controlling SGA hemorrhage when it does happen. So this is a picture of an SGA hemorrhage where this huge hematoma is in the thigh. And as those of you that do trauma know, people can die from these massive hemorrhages, even if there's very little bleeding coming out the skin. This can be enough of a blood loss to lead to hypotension. And here's another case reported by Maxwell, where the reamer came right where the superior gluteal artery is, and you can see the large hemorrhage that came in that situation. So the range of blood loss is usually quite low in these clinical trials, like in the SI bone CFI trial. Average was 51, but look at this variability, 500 to 800 milliliters of blood loss. In the Symmetry trial, it was 0 to 1,500 cc's. These are life-threatening things. You do this in an outpatient setting, and good luck when that happens. It's very dangerous. So the lateral approach to the SI joint is the only one where the superior gluteal artery and superior gluteal nerve are directly in the approach trajectory, leading to unavoidable and unpredictable complications. Not only do you get bleeding, but look at this atrophy that comes when you denervate the left gluteal muscles and the tensor fascia lata when they are damaged. So this is just another picture showing the location. You can lose innervation or you can lose blood supply to the gluteus maximus muscle, also contributing to atrophy as well. So the bottom line is you need to get a CAT scan. You need to have careful pre-surgical planning. And even with that, there are risks to lateral approaches, particularly for people that are not trauma surgeons and experienced in putting in lateral screws. The next thing is, how did this happen in my case? And this happens, this risk is there in every SI bone case. The tissue protector is square, the pelvis is not. And when it docks on the ilium, there's this gap where soft tissue can creep in, and that tissue can be yanked on, leading to avulsing the artery. And so this is the exact device in my case where it happened. The docking was right here, but there was this big of a gap, and soft tissue got brought in. And as I was impacting the cage, after I'd done all the work with the reamers and all the sharp instruments, I was just impacting the cage, and the sharp surfaces on the cage must have grabbed soft tissue and avulsed the artery. And I had to make a decision as I was doing it. Do I keep impacting or do I pull it out? And I thought it would, I could control the bleeding faster if I kept impacting. And in that 45 seconds is when I lost all that blood. This is the picture from the lowest trial of how they place these. And this placement of the bottom device is exactly how I did it. So this is what the instruction manual shows. And here's the actual teaching manual showing that the third device is quite low. And that's close to the proximal trunk of the superior gluteal artery. That's a dangerous location. Teaching of the lateral approach has to teach risk mitigation, including the anatomy of the bony and soft tissue corridors, management of bleeding, and discussions of other surgical options. That's mandatory. And you have to discuss that with patients at the time of informed consent. So from the MAUD point of view, this is not an inherent risk of surgery. This is a specific risk for this approach. And the large size of the iFuse device and design errors with the tissue protector raise additional concern. And this is not a general risk of surgery. It's a device-specific risk. And action is required, as opposed to the company that says no action is required. And should life-threatening bleeding from a minimally invasive pain treatment be a never event? And the answer is yes. So these never events are happening on a not so infrequent basis. And on the initial surgical treatment for SI joint pain, where it can't be fixed, like in the days of John F. Kennedy, where his pain couldn't be fixed, yes, risk has to be reasonable in relation to the benefits, but we have better options now, and those must be discussed with patients as well. So now let's talk about other neural risks. The L5 nerve root can be injured at the top of the sacrum, and you can get foraminal injuries at S1 and S2, particularly when you have dysmorphism. When you come from laterally, you can plunge across here and bag a nerve root right there at the S1 region. And when you look at the proximity of these cages to the notch where the S1 root comes right here, and also how close you come to these foramen, it's easy to see how so many neural injuries occur. And this is from the Collins article showing that 3% of the time the L5 root is injured over the top of the sacrum, as opposed to hitting the S1 foramen for the S1 being damaged. Intra-abdominal injury, you need CT imaging. Look at all of these types of different dysmorphic pelvises, and there's even more than this. And this is commonly seen in patients with SI joint pain. When you have a lumbarized sacrum, you have even less room for lateral approaches. You may even get only 2 dowels in there. And where's the pain generator on this one, and what are you going to fix? So you really have to have a good idea. Likewise, when you have a dysmorphic pelvis, the S2 trajectory may be normal, but the S1s can be highly abnormal. Here's a normal anatomy, here's a dysmorphic pelvis. So what looks good on fluoroscopy may be a disaster when it comes to doing things in an outpatient surgery center. So this is what happens if you don't recognize the dysmorphism. This is a normal sacrum, but here this side was dysmorphic, and this device ended up in the pelvis. And I'm not going to tell you how I got all these pictures, but people send these to me all the time whenever they see them in their clinic. Here's a patient with dysmorphism, and it's very easy to miss this on your screening x-rays, but that looks like a really big dip laterally as opposed to a normal sacrum that goes straight across. And this is what the device looked like. It's violated the abdominal wall. And this is the next higher up device. And you can see that the device was drilled, and when the drill went all the way in the abdomen, behind the psoas muscle, all the way to the L5 vertebral body, because the dysmorphic nature of that pelvis was not recognized. If you get into the sacrum, there's the whole sacral plexus. You can get tethering of the plexus rostrally and caudally, tethering on the pudendal nerve and the genitofemoral nerve, and then rostrally up to the conus. And here's the flaccid bladder after that injury, tethering leading to signal changes in the conus and the conus. And it was just fortunate that these large vascular structures, iliac artery and vein, were not damaged by that plunge. So instead of the lateral approach, alternative approaches have to be considered in the index operation for all patients with a dysmorphic pelvis. And the safety data from RCTs are not generalizable, because fluoroscopy may be used exclusively in someone's practice as opposed to trials where image guidance was frequently used. The dysmorphic anatomy is difficult to image in 2 dimensions. 2D protocols, elderly patients have poor bone quality. Blood type and cross may not be utilized in outpatient surgery centers, and trauma surgeons with IR backup are not available in surgery centers. So it's not generalizable to the everyday situation. Bone density, as you all know, is very soft in the sacral ala. So something that anchors in the sacral ala, which is 1/3 the bone density of the ilium, they're probably going to fail in a high percentage of patients. And so laterally placed SI joint devices are anchored in this soft central ala, and you can see the differences in bone density. So if you only get one dowel that goes all the way to S1, and the other 2 are anchored in this type of low bone density on the left, that's not a very good recipe for durability. The central sacral ala is 9 times softer than the S1 vertebral body. So any device that destroys the sacral cortex and relies on anchoring in the soft central ala has a high risk of subacute failure and loss of durability. And this is what it looks like. You've all seen these types of cases with shadows on the medial sides of these devices. They're everywhere. We all have seen tons of these. It doesn't matter what device it is, they're going to fail with a long period of time if you don't have a fusion to hold everything in place. So is the SI bone iFuse predicate data really appropriate? Predicate data is the trauma screw, and a trauma screw has a fusion and compression in the setting of a fracture, not a stabilization where bone has to grow into the device on one side, grow into the device on the other side. The fusion of bone to metal, which is not a fusion, it's bone ingrowth and ongrowth, has to remain durable, and the device has to not break for like 10 million cycles. They don't even test it for 10 million cycles. It's unlikely to be durable, particularly as patients age and get osteoporosis. And the other predicate device is a device used for ankle fractures that's been pulled off the market. So we've got all this predicate device that doesn't really predict anything, and there's no fusion. This is not a fusion, it's a stabilization device with ingrowth and ongrowth, but no bony fusion. So long-term durability is yet to be proven. So what's the preliminary durability data? Radiologically, at 3 months, there's only 16% lucency, 6 months, 26%, and by 24 months, 43%. Clinically, these patients aren't failing at 24 months, but this radiologic projection predicts that there will be long-term clinical fall-off of benefit, as opposed to when there's a true fusion. This is one of my patients that had distraction interference fusion. Even if that device fails, there's a bony fusion, and that device is no longer necessary for this patient. And this is a patient with some poor bone quality with a compression fracture and kyphoplasties. So we really need to get specific, defining fixation versus arthrodesis versus ankylosis. And as we all know, fixation is something that spans a segment, and that's what SI bone does, it fixates it. Arthrodesis is a surgical fixation of a joint by procedure designed specifically to accomplish a fusion of the joint. So that's what our gold standard is. And an ankylosis is where you immobilize it until the joint fuses. And that's what Roy Camille did in the cervical spine, just put screws in until the small facet joints in the spine fused. So these are the three different strategies. We got to be specific. But we all know that if a hip spans an area, that doesn't mean that this will fuse, and the joint doesn't fuse. You just have bone ingrowth onto the device on both sides. So it's got to, that has to survive for up to 10 million cycles for the SI joint. There's no surgical fusion between the surfaces, so it depends on the adhesion of bone to both ends of the devices and durability. This is a novel mechanism. This is not an FDA-approved mechanism, and they call it a fusion in their name. They call it a fusion in all the marketing. Is this a proper 510K mechanism? No. Is it a proper 510 clearance? I will argue no. I think the FDA blew it. I think they missed the point. And this is really transfixation, and it's a fixation procedure and possibly a very delayed ankylosing procedure at best, but not a fusion. If you look at their marketing material, they will tell you, look at this little fusion. They'll show a little 1 millimeter bone growing across the joint in 5 years in one patient. And they're doing that because they know this is a weakness of this problem. So guidance for industry from the FDA that they teach their staff is that this document issued in 2000 says there has to be evidence of bridging trabecular bone between the involved motion segments. That's the definition. SI bone does not achieve the FDA's own internal documents of what they call a fusion. Then there's some coding issues. If you code for a fusion and you're not fusing, is that a coding issue? Mechanism of action risk. In the cervical spine, I'm not allowed to put a cage in without a hole for bone fusion because they don't call a fusion to a device a fusion. Why is it allowed in the SI joint? There's internal inconsistency in the FDA. This is the best picture in publication by Wang 2019. They call this little piece of bone right there and right there an ankylosis type of fusion. And that's in one patient. But look at this right here. That's a pseudoarthrosis. This is what we all see if we look at these pictures. We may see this a lot. I've never seen more than like 1 millimeter of bone. This is their best case in the entire SI bone literature. They've done 25,000 cases, and that's what they got to show for. So that is not a real fusion. The vignette they use for the AMA for billing is working through the soft tissue protector and removing the cartilage on the sacral and iliac side of the joint to employ direct visualization after debridement of the joint. They don't do any of those three things anywhere in any of the teaching manuals, in any of the cases. Removing the sacral and iliac cartilage, destroying the stable cortex on the soft sacrum. That's all you've got to anchor it. They can't destroy that because these things won't be stable without that sacral cortex. So it's critical for the stability. So the vignette for coding given to the AMA is not correct. You can get soft tissue pain when I ask patients that have had two different methods, they always say this method hurts a lot more. You're going through fascia, gluteus medius, gluteus maximus before you get there. This really hurts a lot when you do that 3 times. You can also damage the neurovascular complex, leading to more pain. You can get piriformis muscle dysfunction as well, and gluteal compartment syndrome when there's bleeding into the muscle, which happens frequently. So therefore, we no longer perform routine posterior iliac crest bone grafting due to pain, loss of kinetic chain disruption, and risks of the superior gluteal neurovascular complex because there's safer alternatives. So is the lateral procedure going to become a rarity in the same manner and for the same reason? And the answer is probably yes, particularly as safer and equally effective methods get proven. So it creates a unique mechanism for increasing risk of pelvic fractures as well. Large size of these dowels, 3 of them right next to each other. Jeff's kid gave this to me as a picture. This is what happens when you split granite. You drive these spikes in at a regular basis and you make contiguous holes, and that leads to how you split a piece of granite. The hip is a little bit softer than granite. So yes, there's going to be pelvic fractures. These are reported. Then the other way you can get a pelvic fracture is an insufficiency fracture on the medial side, where the lateral part is incredibly rigid from all these contiguous devices, leading to pelvic insufficiency fractures. These are what are reported on the MAUD website. This is when one of these is rescued, you try to fill it in with bone, you get this pseudoarthrosis rather than a regular fusion. 15 to 20% of these patients have no improvement. 6% are worse in the IMIA trial. And so if you have patients that don't improve or get worse, and you can't revise these easily, and you have 10% of patients in one trial that could walk pre-op and couldn't walk at 6 months, is this acceptable? When you have a bad outcome that can't be revised? And these are all the different mechanisms: nerve injury, muscle injury, vascular injury, failed, unrevised, unrevisable devices, and pelvic fractures. These are big problems. And these problems do not apply to the distraction interference approach from posteriorly or the posterior inferior approaches. So we've got a lot of problems. So there's a need for CT preoperatively for planning for any SI joint surgery, no matter who's doing it, from what field, to choose the safest and most effective procedure for an individual patient, avoid neural injury, and get your best surgical trajectory, and avoid bone graft defects like this one from a previous iliac crest bone graft. Here's another one. You want to know about that before you choose your surgical approach. And Maxwell recommended advanced imaging such as a CT or even a CT angiogram for all lateral approaches to the SI joint to avoid vascular injury. There's a lot of variability in outcome. Like I mentioned before, 20% improvement is considered a success. There are no pain studies, as you all know, that use that low of a threshold. 50% is generally considered reasonable. If you use a 50% number, only about half of patients reach that threshold. Is that a success? So this is what they're reporting, but how many of you read that little qualifier over here? Clinically important pain relief is greater than 2-point drop. That's hidden in plain sight. Here's the real data. When you do a scattered plot, and this data was provided by SI Bone when I asked for the raw data from the inside trial, almost half the patients have less than 50% improvement. And these are very tough rescue operations. That's a lot of patients when you can't do a rescue operation to leave with no alternatives. So this is what's published. This is the real data. Variability is not clearly reported, and I could get into the statistical ways that data was obfuscated as well, but that's a whole separate discussion. When they use standard deviation, standard error instead of standard deviation, that makes it look a lot better. But this is the type of variability that's common to all methods of SI joint fusion. We've got to get more reliable. The issue is that knees and hips work 95% of the time. SI joint works 80%. I'm sorry, spine works 80%. We're not there yet. And SI bone and all methods work about 80% in the SI joint as well. We've got to get it up to the hip and knee threshold of 95% success. Let's skip all the opioid use. What's reported by industry and by academics don't correlate with the lateral device. Supplementation problems. This is how complicated these types of cases can get. They become quite challenging. These are courtesy of Woody Cross, who seems to have a cottage industry for people all over the country that need these revisions. And at some point, it becomes a metal fest of different supplements, and it becomes very difficult. So you want to be able to have something easily revisable and easily removable or supplementable, or even better, both. Next, these things block important corridors in many cases for supplemental instrumentation. How do you get a posterior inferior supplementation here? You've blocked that corridor. If you end up needing to do a long construct on top of this, you have to use an S1 medialized screw rather than a alar screw into the ilium, because the corridor is blocked, like in this example right here, when one of my colleagues couldn't get around these SI bone devices. It's a low revision rate, fair to report, if the device that fails is difficult to revise, and no one is doing it except for Woody Cross nationally. Most people that are putting these in are not revising them. So you've got a high degree of variability, 15 to 20% of patients failing, and you can't revise them. That's not a success. So that leaves patients with failed surgery and no recourse. And this is a class of harmed individuals when there's other FDA cleared devices that are revisable or supplementable. And this guy is a minister who had to retire when his operation didn't work. And I had to send him up to Woody Cross. It took him about 7 years to get his problem fixed because he couldn't find recourse until that was fixed. I just saw him back in clinic. He's doing great, but it was a big deal. So therefore, surgeons may reconsider recommending SI bone not only for patients with pelvic dysmorphism, but for all primary operations. These are specific risks, not general risks. And this means there needs to be a big increase in how these are taught. There's training problems. These are all the specific risks to SI bone. And in the community, this is even magnified. The Pearl Diver evaluation demonstrates a 16.4% complication risk, not 3.5%. So that's probably more likely to be what we're getting in the community, where there's fluoroscopy. Type and cross blood is typically not available. There's no expert backup for bleeding, and the risk benefit ratio is suddenly becoming the front page problem, and we need to do better. So I'd like to skip forward to distraction interference procedure, where John Stark had 10 years of data, and I've replicated a lot of this, where there's generally 25 cc's of EBL, 1.5 day length of stay. And Jeff Donner has had excellent open results using the posterior inferior method. Distraction interference, you come through the midline, go down to fascia, expose the medial side of the ilium, make a vertical incision, go right down the side of the ilium, put a guide pin from S2 aiming towards the femoral head, distract the dorsal recess, put a cage that put a guide that holds that distraction, ream it out, and put a cage in that holds the distraction, widens the joint, and you get fusion through the device and fill up the dorsal recess above that. And this is our data. This is at 2 years out at clinically significant improvement, with 83% of patients having greater than 50% improvement and a p-value of 0.0001. This is very reliable. Our fusion rate was about in the 82% region, or 80% region. 94% of patients improved by 2 points or more. So this is much better data than what is being reported with the lateral approach. This is other data that we have to support it. 10.5% of patients were revised. But what makes this operation great is if it fails, you just open up the incision and go right down to the back of the cage, unthread it, and ream it and put in a bigger rescue cage. So if it works 80% of the time, that's generally all you need. And there's easy backup surgery for round 3 if it gets to that stage, which it occasionally does. And eventually you get it right so the patients are better. The fusion rate in our series was about 90%, and it's easy to revise. So the higher revision rate is because it's revisable. That's how it's designed. It's not revisable. So our numbers are different. There's a learning curve here. And after the first 12 cases, we only had 2 failures. And this is the Insight trial scatter plot. This is ours. It's plain as day to the naked eye. When you look at scatter plot to scatter plot, this one is much more reliable. SI bone is first to market, but safety is going to become the driver because efficacy, we're getting there with other devices. There's a lot of ways to fix the lateral approach and make it safer, but there will always be unavoidable and unpredictable injuries, including death and pelvic fractures and challenging revisions. So never events should be never events. We need to focus on other methods of doing SI joint surgery that are safer. I'd like to skip.
Tom, do you have a summary, a slide, a closing slide? I think we had some more.
Well, these are the recommendations. Just have blood available, do it in a hospital setting. If you're doing lateral, inform patients of these risks that we've talked about and that there's other procedures and there's no way to predict who's going to have a failure, and make sure you discuss and informed consent these types of issues. And you need to be properly mentored in a hospital setting by a surgeon for all of these techniques. We're not there yet. These are what we need for an ideal device. And last, the posterior inferior method. We don't have a lot of published data on this, but I think this is probably the method that is going to be widely adapted by the many different types of surgeons because it's safe, relatively safe, and feasible. These are just some pictures showing the types of devices that are being used in the posterior inferior approach. And Jeff Donner has been a real pioneer of this, but Bruce Dahl has also been in this space as well. And that's the trajectory for the posterior inferior approach. I'll stop there.
Well, thank you. That was really thorough and obviously needed because we hear too much, I think, from the industrial side. And again, they have a lot to contribute, but we need to look at this honestly and fairly. And I agree with the concept, you know, safety first. I mean, if it's not safe, everything else doesn't really hold up. Obviously, efficacy and then durability. You know, with that, I think, did you want to have questions or did you want to move on to the next section?
Well, yeah, let's have Dr. Freeman stay on with us. That was really an amazing presentation, really eye-opening for a lot of us. This really kind of dovetails in nicely to our next panel. So if we have our next panelists jump on, Dr. Beal, Dr. Bovenet, Dr. Cross, Dr. Freeman, and Dr. Orfanos, we'll kind of jump into some questions. And I think Doug maybe wanted to set up this panel with a few slides. Was that correct, Dr. Beal?
Yes, that's right. Well, again, if you could put those slides up. This everything we talk about is predicated on these surgical trajectories and approach, and Tom Freeman did a nice job with that. There's 7 different trajectories. Next slide. It's all the way from you know, the subgluteal transiliac approach all the way back to Smith Peterson in 21 until the early 2000s. And the anterior column approach, you can do an anterior fusion, posterior fusion. And then, as was previously described, including Mark Riley's description in 2010, the laterally placed transfixion of the internal screws placed laterally. This is the extra-articular and intra-articular posterior approach. This is done by numerous people, including Weisdahl, Fuchs, Rule, all the way down to the labeling is not showing there on the left, but all the way down to the previously described extra-articular arthrodesis by John Stark in 2010. Also, our own Jeff Donner did quite a bit of work in this posterior approach, especially posterior-inferiorly. The three approaches, lateral, posterolateral, and posterior, are the most commonly used. The posterior-inferior approach, believe it or not, was first done by C.F. Painter in 1908. 33 days in the hospital, took 9 weeks to recover from, and it was a real big hit. The posterior extra-articular approach, as was shown previously, this is a approach done along the lines of the anterior column, the weight bearing. It's a distraction arthrodesis, typically done with bone graft and a slightly conical screw that also has the capability to be revised. And then the posterolateral approach with the approach just medial to the gluteal muscles right there, and the approach is perpendicular to the SI joint. One of the advantages to this approach is you miss the gluteus max and med, so it goes just medial to the gluteal muscles, as opposed to the trajectory by the lateral approach. This is direct lateral with dilation of the soft tissues, and as was mentioned, the proximity to the dorsal branch of the superior gluteal artery. And that's one of the concerns and one of the advantages of the posterior approach, which the trajectory of the posterior approach is medial to the neurovascular bundle of vasculature, and lies, there's nothing really distally there, all the way out through the iliacus muscle. And so this is an example of some of the posterior dowels. Allograft dowels are oftentimes placed with the posterior approach. We can have examples of bony fusion both soon, early, and also late. This is at 24 months. And the posterior approach can also be used as a salvage for some of the lateral and posterolateral approaches. And that's all the setup I wanted to do. All of the goals of all 7 of these trajectories, including the 3 that are primarily used, is safety and efficacy. With that, I'll turn it back over to you, Dawood.
No, that's really great, Dr. Beal. It's really good for us to see. I'll go back to that intro slide. We're still not ready for this panel just yet. Dr. Bovenet, Dr. Beal kind of ended there with some slides and CTs and posterior allograft type technique. You've been someone that's been a kind of a pioneer and someone that's really adopted that into your practice successfully. Can you give us a little bit of why you choose that approach and what are some of the advantages of that for you in your practice?
Yeah, Dr. Freeman did a great job summarizing everything and the risks of the lateral approach. And as a physiatrist first, with only a 10-month history of ortho prior to going to PM&R and then doing my pain fellowship, I didn't feel that I was adequately trained to do that lateral approach. So the risk mitigation is why I went for that posterior oblique approach, with the distraction technique, avoiding any major nerves and vessels, just as long as you could find that SI joint. Obviously a 3D structure we're trying to get in looking at a 2D image. So just as Dr. Freeman said, I've been utilizing advanced axial imaging, whether it's the CT scan or the MRI, looking at those axial imagings, measuring my angle and planning it out before I get in there, comparing that to our cut lines on the sagittal, so I know my CC tilt to best get in there around that S1 foramen, looking for the dimorphisms, those, the sacralization of L5, lumbarization of S1, see where we're going to get in there. And we've had great success with that. We have our published literature out there in our single arm prospective study, showing there about 1.3 minutes using this posterior approach. As far as fluoro time, I've cut it down to around 30 seconds is what I'm utilizing from the time the very first picture's taken to our final safe picture. So fluoro has been cut down, blood loss has been less than 10 cc's, and this is tracking every one of my patients with this particular posterior approach. I'm at around 340 of these procedures now, and we have data at minimum 6 months out on 208 patients, compiling 275 implants, and we're seeing a 98.6% success rate to hit that 50% threshold with an average pain relief of 85.6%. I've seen 55% reduction in opiates and 40% come off completely with 0 infections or broaching any pelvis and any CTs we've seen. And some of those pictures that Dr. Beal showed us were from my patients. So I know we're short on time, so I'll pass it off there.
Really nice summary. That's really impressive data and evidence and experience that you've been able to collect at this point. So thanks for leading the way on that. I'm going to have Dr. Donner ask Dr. Cross the next question. If he's not, then I will. Dr. Cross, pretty impressed by the practice you've built for yourself over there at the Mayo Clinic, and really revising a lot of these, so when you see this, it looks like a lot of your experience has been with, revising some of these failed lateral approaches. So kind of what's your workup for these? What do you do?
It's relatively the standard workup for the primaries, and I work heavily with our pain medicine colleagues for injections to really inject that caudal aspect of the SI joint. I like to see the injection myself to make sure that it's accurate, and I love the conversation about injectate volume, and the max volume tend to give us a false positive by getting extra articular. We want it to stay in the joint. So just that combined with the history and then the physical exam. I also love the comments about the specificity and sensitivity of some of our exam findings. They have to have at least 3 of the 5 core tests positive in my hands. So relatively very similar workup. The challenge for us with revisions is sometimes the imaging isn't entirely consistent with a fail. But it certainly helps when you get the CT scan and there's halos around the implants, or it's completely not in the SI joint or what have you. But it's just a comprehensive physical exam, very similar to our primary exams.
Great, that's awesome. Thanks for that input.
Thanks, Woody. I just want to follow up on that. I mean, Dr. Cross has done over 500 cases, a lot of revisions, and he has a lot to offer. He does use a transiliocecal approach, but he has a more limited corridor that seems to be safer. I think that needs to be called out. And also the fact that he does a compression screw with AO principles getting a fusion for durability. The other issue is he sees a lot of revisions, and he can probably speak to what the toll is on patients if they don't get a surgery that works reliably well and safely the first time.
Yeah, it's a challenge. Yeah, I think to comment on my approach, being an orthopedic trauma surgeon, it doesn't matter what type of sacrum you have or what type of pelvis you have. It's broken, we're going to put it back together. And so we spend our fellowship kind of learning about the dysmorphic sacrum and the nuances of determining what's a dysmorphic sacrum. So that anatomy and the radiographic representation of the dysmorphic sacrum are really secondhand to trauma surgeons. And so although with Dr. Freeman's discussion on the risks of the lateral approach, I don't particularly agree with some of those comments as it comes from an orthopedic trauma surgeon, where we recognize that the 3rd implant and sometimes the 4th implant that is very caudal and posterior right next to the notch. I mean, nobody puts an implant there because that's when bad stuff happens. And so that's why in trauma surgeons we just don't enter that area. That's pretty dangerous. So I think lateral approaches are safe. Again, I've done I don't know how many pelvis injuries with lateral approaches, and then to add on the SI fusions in addition, I think it's pretty safe. And knock on wood, I haven't had a vascular injury like Dr. Freeman, and nothing changes our practice like a complication for sure. To your point on revision surgeries, patients are it's treat every patient like it's your mom, and some patients get surgeries that just unfortunately don't go right, and they're sometimes told that they're doing okay and that they have a fusion in there, but I'll get the images down there and it's clearly not the right place, or it's loose, or there's halos, or there's some other issue down there that they weren't told about. And that's probably 50% of the people that we see up at Mayo. So we do get great results. We're just publishing some of a revision series from a few years ago, but I think they don't do as well as the primary patients. Oftentimes there are secondary pain generators, which is where our pain medicine folks are just awesome to kind of help out with these differential injections. The hip is a big player, so always look at the hip. The facet issues at 5'1", 4'5" are huge issues, so missed facet issues. Stenosis above is a 3rd issue that is overlooked sometimes. So failures aren't sometimes just because there was an SI surgery gone awry, but there are other issues. And so I've replaced a bunch of hips that it turns out it's the hips, the primary pain generator. How do we do that? Ultrasound guided hip injection. So I use what you guys probably use as your terminology. I turn patients into pin cushions, and I will inject until we find the one that works. And that's probably a hallmark of a revision practice.
Yeah, really great points, Dr. Cross. I think not very much different than a lot of us in pain management as well. Dr. Orfanos, I've spoke with you many times about SI fusion. I know that you've been someone that's been kind of in the lateral approach due to the overwhelming data and evidence. Now that you've kind of seen the field evolve. Has your thoughts kind of evolved as well too? Is there maybe a different way that you foresee yourself kind of doing SI joint fixation in the future?
I think just some general, comments about it. No surgery is routine, obviously. I do a lot of lateral approach surgery, and I treat all these operations, very seriously. Now, the things about it that I like are the anatomical landmarks that we can use to try to reproduce these things. Now, the SI joint is very dysmorphic, but I think if you use good clinical judgment in how you place your grafts, and when you look at the SI joint and you look at the landmarks and the demarcations of the SI joint where you're placing, and don't get too aggressive in terms of size, length, all these things, if you use blunt needles instead of sharp needles when you get close to a foramen, and, be very judicious with your oblique views to make sure that you're outside the foramen. I think there are still ways to make the operation safe, because obviously it's a very commonly used approach for many different things, like Dr. Cross spoke to also. So, I think that, obviously any surgery can be unsafe, and I think if you just take a very methodical approach to it from the diagnosis all the way up to the operation, like I said, using CAT scans, paying attention to bone quality, I think, all those things, really should be part of every decision-making process when we choose an operation, no matter what it is. So, and as long as you, adhere to those, then, you can typically get things done very safely.
Thanks so much. Gentlemen, in the interest of time, we're going to jump into our next panel. I think a couple of you are staying on with us. Thank you so much for your time and all of us learning from you tonight.
Just want to make one thing clear. The guy on the far left that says E. Jeffrey Donner, that's Thomas Freeman. He lives in South Florida, in the Tampa Bay area.
Very important point. So let's jump into safety and risk of sacroiliac fusion approaches. Dr. Freeman obviously did a wonderful job kind of pointing out some of the risks of the approaches to fusing the sacroiliac joint, specifically from a lateral trajectory. Dr. Mehta, you've been someone that's incorporated SI joint therapies in your practice for several years now. What are some of the things that you think about? You obviously do this in an ambulatory center when you're kind of thinking about the risks and safety of your SI joint procedures that you're going to do.
Yeah, I think first of all, I think it was Dr. Freeman, I think presented just a wonderful, it was like you said, Dawood, it was eye-opening. I learned a lot, about from soup to nuts, the lateral approach and what comes with it, right? So I got trained in the lateral approach first many years back, and then kind of shied away from a variety of those same reasons which were presented earlier. And I dived straight into the posterior approach, done about close to 300 cases between a variety of companies. And I think I agree. I think there's an element of safety in when you're doing the posterior approach. And now we have proven from the SECURE study, as well as from anecdotal evidence from my cases and Chris Bovenet's cases, that I think this is a very safe procedure. Not only that, it is it's truly minimally invasive, and it's equally efficacious. And I think all these patients, when we followed them up for a year and a half, are just doing amazing. More than that, for interventional pain space for us, where we have done a lot of spinal cord stimulators, used electroceuticals, I think our key challenge always has been identifying pain generators, which were underestimated in the past. And I think this really serves as a way to keep your eyes on what are the other pain generators which could make spinal cord stimulation less efficacious in patients. So overall, I think I'm really blessed to be born in private practice when this concept was emerging for us, where we could basically achieve the sacroiliac stabilization fusion by the posterior approach. So it's been a great therapy for our practice.
Thank you, Dr. Mehta. Dr. Donner, would you like to give the next question?
Yeah, I mean, obviously, everything has risks, and they vary from surgeons' training and their experience and their capabilities. So we need to recognize, if anything, about what we're doing today is there needs to be a place where we can have surgeons trained or interventionalists trained where it's safe, and not allow or expect or depend on industry with their one device to kind of lead us down this path. I think at some conclusion, we should find a way we can work together for our patients' sake. That's my comment. Dr. Cross, what do you think about that up at the Mayo Clinic?
Right, I think it's clear from this talk and others that just like hip replacements, there's a lot of different ways to do things and get good results. And it's clear that posterior approaches, lateral approaches, posterolateral approaches, collar recess, open approaches, everything if it's done well by a well-trained surgeon who's comfortable doing it, or a proceduralist, it's great. So there are different ways to do it. We just need to make sure that they're done well. And I think that's where education like this seminar really hits home. So I like an open playing field, continued investigation, just like Dr. Med is doing, and Dr. Bowman, and everybody's following their results. And that's critical, because that's how we publish data that shows everything works, and we can have an open, like Jeff, you heard we talk about this a lot. We need an open playing field, because there are so many different ways to do it. There are some ways that are better than others when you other things going on, like if you need iliac fixation, but you have 3 or 4 bolts going across there to block your fixation for surgery, that's a problem. That's where a posterior approach may be beneficial. So all these approaches are great. We just need to follow the data and let data speak about which ones are working.
Tom, do you want to comment?
Okay, so fortunately for Woody, I was muted when he was trashing me, but what I'd like to say is I agree with Woody completely that bottom trajectory is very unsafe, and that's how I got in trouble. But I also showed their publications and their instruction manuals show that's the normal placement of the third dowel. They also have data saying that if you only put 2 in, the results are not as good as if you have 3 points to determine a plane. And it's the sacrum, the joint is like a plane. You need 3 points of fixation from that point of view. So it's a sticky wicket that they're being taught. We're all being taught this method of operating on the SI joint that doesn't go in conjunction with what trauma surgeons are being taught as a no-go zone. These massive bleeds are occurring with the third dowel right next to the trunk for the superior gluteal artery, which gets into the point that Jeff made, which is our training. You can't train in 4 hours to do SI joint surgery. So when industry is training, we've got a big problem, because they want to sell widgets, but in 4 hours, you can't learn what takes a 1-year fellowship to get, and mentoring and proctoring in the operating room. So the teaching then becomes a liability. Who is responsible for the poorly taught surgeon that is told you can go out and do this, but there's no certification process? So this is a startup problem with the field where there's so many different devices and so few people teaching this in a proctored and mentored manner. So I think we all have to be cognizant of that as we start up, to make sure we're surrounded by colleagues that can help proctor us in this new field and go slowly and carefully.
Great points, Dr. Freeman. Dr. James, we spoke a lot about safety and the certain risks. So when you are doing an SI joint fusion, what's your setting? Is it inpatient? Is it outpatient? Do you have blood type and cross available? All those things, kind of, what's your setup, and do you think that'll change in the future?
Great question. And I just have to say, it's such a pleasure to be here among all of you with such passion for treating SI joint pain. I was not trained in it in my residency training, and I took a course industry sponsored back in 2014 with SI Bone and was abhorred by it, and only started doing it 6 years later when I did another course, and I realized there was a place for it. But I do operate exclusively in the outpatient setting. I do not type and cross. That has not been an issue for me yet, thankfully. I do all approaches. So I also do my own diagnostic injections, and I highly recommend that to everyone out there, because it gives you time to get to know the patient's anatomy more intimately. You are working in a 3D plane with your X-ray in different views. You know that you're definitely in the joint. You can trust yourself that this was an accurate diagnostic injection. And if they get well, I have to have 100% pain relief after the diagnostic injection for a minimum of 12 hours. And then I separate patients into mild, moderate, and severe SI joint pain. So the mild cases get several weeks to several months of pain relief after the diagnostic injections. The moderate cases get several days to several weeks. And the very severe cases are patients who can barely walk into the clinic, and they will get at least, I require a minimum of 12 hours, 100% pain relief after the diagnostic injection in order to qualify them for an SI joint, what I call fixation, stabilization, or fusion surgery. The other thing I wanted to mention that hadn't been mentioned yet this evening is I really think it starts with a clinical diagnosis when you're taking a patient history when they first come into your exam room. So the questions I ask all of my patients who I think might have SI joint pain even before the exam, I say, does it hurt to stand up? Yes. Does it hurt to roll from side to side in bed at night? Yes. Does it hurt to get in and out of your car? Yes. Does it hurt to go upstairs? Yes. So if they've said yes to all those questions, then I will definitely do the SI joint exam. And for me, I have to have at least 4 of the 5 diagnostic maneuvers positive before I move forward with diagnostic injections. And then I explained my approach with the diagnostic injections. So back to the surgery center in terms of safety, I think my advice to everyone out there is just go really slowly with your X-ray imaging in the OR. Make sure everything is lined up appropriately and that you're really satisfied with your X-ray images before you incise, advance your K-wires, or whichever procedure you're doing, posterior or lateral. Just go slowly, especially at first.
I agree with that.
Thank you so much for that. And again, thank you so much for this panel. We're going to move on to the next one.
Someone like to begin the discussion on the data from SI joint fusion surgeries?
Sure, I'd be glad to. Can I have I have like 4 slides. Okay, just briefly, some of this has already been reviewed. I just want to briefly set the predicate for what I'm about to talk about. This is the work of Brad Duhan, who at the time was one of my partners when he was in Texas. And this is from the Sci-Fi study, and very briefly, 2-year outcomes, fairly impressive decrease in pain overall in terms of the overall mean at 24 months, and somewhat less impressive improvement in ODI, but reasonably good. Interestingly, at 1 year, only 22% of the patients on CT showed evidence of bridging bone, but I'll come back to that in a moment. Let's go to the next slide. Also in 2016, it was a good year for SI bone. They had 2 very good publications. This is from Dr. Colley, and this, of course, is the INSIGHT study, the 2-year data. This was an RCT with Andy Redman, one of my other neurosurgical partners. We contributed a few patients to this study. This compared the SI joint fusion from SI Boone to non-operative care. This was an RCT, and that included just about everything, RFA, SI joint injections. And you can see that the non-operative group, they did not do well at all, but when they crossed over, they did just as well as the rest of the cohort that got the actual stabilization procedure. Next slide. Patients from both of these studies were invited to follow along for another several years, and this was the lowest study. This is 5-year outcome data, and you know, if you just look at the graphic on the right, the data is good. These patients had a decrease in VAS, an improvement in ODI, and both of those indices maintained out to 5 years. And I think interesting is that at 5 years, reportedly CT showed bridging bone in some 85% of these patients. Next slide. Now I want to take the liberty of briefly presenting 12-month data from a study that's being carried out currently using a posterior allograft. I will say that perhaps I am a member of the Dead Bone Society, as my friend Ralph Rashbaum always tells me, but nonetheless, the data speaks for itself. At 6 months, the VAS improvement was quite impressive. 68% of patients had better than a 20-point improvement in VAS. And let's explore that a little more. At 12 months, 77% of patients had greater than a 2-point improvement in VAS, and 67% had greater than 50% improvement, and 42% had greater than 80% improvement. And listen, if you got somebody who's had chronic pain for years and years, and they tell you that they're greater than 80% relieved, that's a very significant success. ODI was also quite impressive in regards to its improvement, particularly at 12 months. And notice that these patients did better as they went from 6 months to 12 months in this study. ODI baseline was about 52 in the 12-month group. And after the study, after 12 months, ODI mean was about 26. So greater than 15-point improvement, which was a predetermined endpoint for this study, 67%, 2/3 of the patients met that level of improvement. Next slide. And we've seen this slide a moment ago by one of my colleagues. I like this study. This is Chris Martin and David Polly looking back in 2020 at 18 studies, different manufacturers, different approaches, different implants, looking at both ODI and pain scores, taking overall weighted means of pre and post procedure at 12 months for both ODI and pain scores. And I'll bring you to the graphic on the right very briefly, and you'll see that pain scores dropped significantly across this group from the 8s down to the low 3s. And ODI improved nicely from about 56 down to 34 across all of these studies. And basically what that says is that the procedure is done properly. All of these different methods to stabilize the joint can provide clinically significant improvement in both pain score and disability. Now, what I did, I took the liberty of putting our recent SECURE data at 12 months in, highlighted with blue at the bottom, just to show that it compares nicely with all of these other published studies. Our pain scores went from the high 7s down to about 3 at 12 months. And our ODI in our patient group went from 52 down to 26. So really no different than any of these other studies, but the big difference is that this is a posterior allograft and that the complication rate inherently is significantly lower, and that has been seen in our study. We've had no SAEs that were device related in our study so far, and there have been 107 implants in the study. Next slide. I think that's it. So I'll let Dr. Fulowski and Dr. Vu make some comments now.
Great, thank you.
Okay, well, actually, great job, Aaron. I mean, that's actually a really great review of the data. I think it's well known that basically with SI bone, they produce some of the best data we've seen for SI fusion with level 1 evidence. But I don't think it's even disputable that that does come with some safety risk. It's a much more morbid procedure, much more clinically involved. And we do have now the posterior approach and the posterior lateral approach, in which the SECURE data was the first actually good multi-center prospective data that we have to support posterior graft implant. We do have some small prospective studies that support posterior lateral with screw fixation as well. And then we do know there's multiple retrospective studies looking at posterior graft implant and posterior lateral. So I think at this point, what we're starting to see is that we know that the posterior approach is actually a very safe approach, minimally invasive, less morbid, can be done in a surgery center, outpatient, with very little morbidity or risk to the patient. And now we're finally starting to secure that data, no pun intended, with securing the data there.
Yeah, thank you. Great presentation from Dr. Kolodny there. I wanted to highlight that in the SECURE study, we also looked at PROMIS 29. So not only are we looking at VAS and ODI, we're reductions in terms of sleep disturbance, fatigue, anxiety. Patients are able to participate in social activities, and there's also improvement in their physical function, which I think is representative of where pain medicine is going, right? We're looking at patients from a more multidimensional, holistic viewpoint, not just pain scores. Additionally, you know, a lot of 87% of the patients who had a posterior fusion underwent the procedure using MAC sedation, and so they didn't require any additional hospitalization after. And so this also adds an additional safety feature as well. All of the patients doing lateral approaches had required general anesthesia in the INSIGHT and IMEA studies, which looked at lateral fusion. Additionally, when you're looking at device-related complications, so the total number of serious adverse events in the SECURE study looking at posterior fusion were 0 at 12 months. I'm sorry, procedure-related was 0. There were 4 total serious adverse events, usually related to the, I'm sorry, I misspoke on that. 0 implant-related adverse events and a few procedure-related adverse events such as aspiration and whatnot. But when you're comparing that to the IMEA and the INSIGHT, you know, right at with 49 patients in the IMEA study, they had I'm sorry, in the INSIGHT study, they had about 179 adverse events and about 50 in the IMEA study. And so this kind of speaks to some of the safety and efficacy when we're looking at posterior versus lateral approach. And like everyone was saying before, you know, when we're picking the approach, you know, we should really pick what's safe and efficacious for the patient. So if we're seeing similar safety, similar results with a posterior approach and less risk, you know, it kind of makes sense to think about this as your treatment for SI joint dysfunction.
Great, thank you for the summary. Wow, 3 different perspectives. I understand Stephen and Aaron, you're neurosurgeons, correct? No?
And I'm just a spine interventionalist, interventional pain medicine doctor, but I practice as part of a neurosurgical group, and Brad Duhan was one of my partners when he published that report, 2-year report.
So that's a good cross look at a variety of different techniques you've been doing, but I agree. I mean, I have my own fluoroscopy room, and I truly believe I can do this like a like kyphoplasty in my office using the posterior inferior approach anyway. I don't use the distraction interference. I like to use intra-articular fusion technique. I think this is where we'll be heading, and it'll be great for patients not to have all the extra risks. Is there anyone else who's on who would like to ask a question? Or I think Dogwood lost his internet service, so we're on our own here. Can someone help me with the rest of the program to know what we have left before we decide how much more time to spend?
Well, I have a question for you and the other surgical colleagues that I'm curious about. In the you mentioned that your colleague, Dr. Fuchs and Dr. Rule, you know, they published their distraction arthrodesis series of quite a few patients, 170 patients, using a hollow tapered titanium screw placed posteriorly. And what I thought was interesting is that the how the patients did clinically did not correlate with their CT scans after surgery. So there did not seem to be a direct correlation with evidence of true fusion and clinical outcome. And I'd like to get your thoughts on that. And also, you know, it's interesting that they used BMP2 on some of their patients and noticed at least doubling of their fusion rates.
Now that's a good point. I think Tom Freeman, if he's available, he can speak to that better if he can jump back on. But I can tell you, yeah, I mean, obviously there's a big gap when you look at the extra-articular portion of the SI joint. I mean, it's It's not the best kind of bone to fuse to, as you can imagine. It's under tension, not under compression like the articular portion of the joint. So obviously infuse would help in those big gaps. Tom, do you have an idea why it didn't correlate between fusion and outcome?
Well, part of it is all of these devices, before they fail over a 2 to 5 year period, will show some benefit. The distraction interference technique, I think you get a lot of benefit right off the bat. My patients where I use that technique, they're better the fastest. If they have referred pain to the groin, the thigh, or pseudoradiculopathy down the leg, they'll notice that in recovery room. So you put the capsule under distraction, and that eliminates some of the pain generator. And so if you have follow-up data at 2 years with the pseudoarthrosis, if the cage hasn't subsided at that point, even with a failed fusion, you'll still have some benefit. Durability is a different situation. The fusion rate, I think they got, was in about the 36% range, if I remember correctly. And, you know, like the data I showed earlier, we got about a 90% with BMP. And that was with the initial Diana device. The beta version, which is the Ilion device, the Nadia device, is placed lower down where the dorsal recess is much more narrow to help get rid of that problem of trying to span a 13 or 14 millimeter gap, where fusion over that distance is more prohibitive and requires BMP in order to make that work. So I think there's need for innovation, and I think we're now working about innovation of efficacy and reliability, and we're all realizing that safety is driving things at this point. You know, the point is we got to publish. As a group, we all have to publish our data. SI-BONE has done a very remarkable job of putting out a lot of publications. We can argue about how they presented data, and is it lipstick on the pig, or is it good? Are these good papers? I think they're good papers with a little bit of lipstick. But I think they've put out a lot of good papers, and it's up to all of us to present efficacy data. I'm putting on my David Polly hat. And you know, his point, which is well taken, is without robust prospective trials that are rigorous, the onus of safety, proving safety and proving efficacy is on all of us that are advocating different methods.
That's a great comment. And, you know, even in spine surgery, we know a lot of times that the fusion doesn't correlate with pain relief as well. So obviously the goal is to identify the pain generator. Number one, you got to have that. Number two, you have to have the right patient, all those things that we know about. And trying to get a fusion in the best possible way and the most robust type of fusion is clearly what we want to achieve in order to have the highest chance of success. I think that's true in spine surgery or SI surgery. I don't know.
I am back now, finally. I think
Oh, here you go. Maybe we should then, any more questions in this section before the billing? Yeah, this is important. Obviously, you know, sad to say, as much as we like to take patients and take care of them and help in the life, if you can't bill and code and collect in the hospital or the facility, I'm probably sure we would take care of a lot more of them than the other side of that equation. But could you maybe enlighten us, Michael, on what you found?
Hey, good evening, everyone. Can you hear me, Dr. Downer?
Yes, I do.
Okay, perfect. My name is Mike Mydra. I am Senior Vice President for Health Outcomes and reimbursement at PainTech, and my disclosure is that PainTech, by the way, markets the Link SI joint stabilization system. So I want to make sure people are aware of that. In terms of agenda tonight, what I thought I would do is give a historical perspective. I'll talk very briefly about what happened last year in 2022. I'll talk about the AMA CPT editorial panel decisions. I'll talk about CMS's OPPS and ASC rule. That's the outpatient prospective payment system, and the ambulatory surgery center rule. I'll talk about 2023 this year, the Category 3 CPT code 0775T that went into effect. And I'll also talk about what's on the horizon here in about 10.5 months, the new Category 1 CPT code that's going in. So if we can do the next slide, please.
Accessibility options.
Coming in from outer space.
Yeah, can we go to the next slide? There we go. So in terms of the AMA CPT editorial panel, in May of last year, the AMA CPT editorial panel, they developed a new category 3 CPT code. It is 0775T. It is arthrodesis, sacroiliac joint, percutaneous with image guidance, and includes the placement of an intra-articular implant, bone allograft, and synthetic devices. And what the AMA CPT editorial panel did is they issued what they call parentheticals. It says for percutaneous arthrodesis, sacroiliac joint with a transfixiation device, you would use the 27279. For removal or replacement of the SI, the intra-articular implant, you would use 27299. And if you're going to perform the procedure bilaterally, you would report the 0775T with a 50 modifier. As I said, this has been in effect starting January 1st, so we're about a month into it. And if we can go to the next slide, please. So the question then is, will Medicare reimburse for CPT 0775T? Question is, will reimburse both on the physician professional fee and also the facility? So if we go to the next slide, please. So what CMS did is they published their 2023 OPPS and ASC rule in November. And again, the OPPS and ASC is the outpatient prospective payment system and the ambulatory surgery center rule. Specifically, what CMS did is they said that 0775T and 27279 do share some clinical similarities. So if you look at that chart on the bottom right there, what you see is that CPT 27279 and 077T, they were basically put in the same APC, the ambulatory payment classification. So what CMS in essence did is they said they're going to crosswalk 0775T to 27279, put them in the same APC with the same payment rate. So in terms of what's going forward in 2023 here with Medicare reimbursement, we anticipate 0775T is going to be akin to 27279 in terms of Medicare reimbursement. Now, having said that, it's going to vary significantly geographically across the country. So rather than give specific dollar amounts, what I would offer is if anyone wants to after the webinar or in the next day or so, if you'd like to contact me, I will work with you to try and get the exact Medicare reimbursement for your particular geographic area. Next slide, please. So in September of last year, what the AMA CPT editorial panel did is they converted the category 3 to a category 1. And I'll read it to you. It's percutaneous arthrodesis of the sacroiliac joint using placement of intra-articular implants without placement of the transfixiation. So the 2X00 is a placeholder. We will know what the actual CPT number is probably within the next couple months, and I would be happy to forward it on to that as soon as we determine what that is. In terms of the timing, as I said, this is going to be effective January 1st of next year, so we're basically about 10.5 months away from this. And so I think that is my last slide. If we can go to the next one, though, I believe I have one last one. Yeah, you can't talk about billing and coding without a disclaimer. So I think with that, I will pause since we're running a little bit late. I will turn it back to you, Dr. Donner.
Thank you for that. I know it's a very complicated topic, and I hear it over and over again, and I just amazed how complicated this is, but we need to get through it because obviously it's going to determine what surgeons and interventionalists will do, and our patients' best interests are at stake. So we want it to be fair. That's all we can ask for. If we could look into the next slides, just to kind of maybe mention.
I'm back, I think.
Oh,
Can people hear me? Yeah, sorry about the technical difficulties. I really just want to thank everyone that joined us, and I thank Jeff for bringing the SIMEG team over and really, having our fields, cross-pollinate on a lot of this stuff is really eye-opening for many of us. So, we hope to continue to do programs like this in the future. Sorry for the technical difficulties, but I think we all learned a lot. We had several hundred people on today live, and we'll have, usually more than 1,000 people watch the recording. So this is going to get out there a lot. So really, really fortunate to have you guys join us. So just a few kind of closing announcements. We're going to have our fellows webinar on February 28th at 8:30 Eastern. It's going to be great interpretation of MRIs for lumbar spinal stenosis. Next slide. And then obviously our ASPN 5th Annual Conference, July 13th through 16th in the Fontainebleau. Hope you all can join us. We're really starting to put together the finishing touches on the agenda. We'll be inviting our faculty here in the next few weeks. So look for those invitations, and hopefully everyone can join us. It's going to be a great time and a good time to get together and learn about everything that's new and innovative in the field of pain and neuroscience. And with that, I think it's a wrap. Thank you everybody for your time. Appreciate you guys all sticking around, and hope to see you for the next one. Everyone have a good night.
Right. Good night. And we're very pleased to be part of your group, and look forward to further collaboration.
Thanks, Jeff.
Take care.
Good night.
Good night.